This second case is really cool. It's cool for a number of reasons, and it also illustrates one thing that has been my blind spot when I get caught off guard. Most of the cases in which I find out after the fact what was up with a patient, I just couldn't figure out what the problem was. Usually it's been some kind of seizure activity, and I missed it. And seizures are very, very different depending on what part of the brain they originate from and what kind of seizure it is. So your standard tonic-clonic in which the whole body's twisting and classic seizure, those are easy to spot. But you get those focal seizures that are from a very small portion of the brain and there's some kind of bizarre physiological effect on the patient. Those sneak past me. And so I'm much more alert to them today now that I've had some learning experiences. Not to say that this call is all seizure, because it isn't, but it does illustrate how things come out of left field when you're not expecting them. This one started off as a 911 call in one of our service areas to a assisted living facility. We have a 77-year-old male here who weighs 165 pounds, and you see here the primary impression is back pain. Let's take a look here. You can see the medications and allergies, and you can even see the vital signs here, and there's nothing really outrageous. Let's focus here on just the history here, just to make sure we understand what the potential or what the range of things we're going to think about when we put together a differential diagnosis, which is a list of all the things we think might be the cause of what we're seeing. So we have anxiety and chronic back pain, depression, diverticulitis, hyperlipidemia, everyone's got that, hypertension, hypothyroid, and bilateral stenosis of the carotid arteries and spinal stenosis. So in this list, you start to wonder which of these conditions might be leading to whatever we're seeing in the patient. Again, the chief complaint, back pain. We have a chronic back pain patient. We have not a lot of endocrine history. We don't have diabetes, things like that. We don't have a lot of cardiac history. We just have hypertension there. And we do have the diverticulitis, so possibly GI stuff too. So when you're thinking about a differential diagnosis, developing the list of things that might be the explanation behind what the current chief complaint is, we don't see a lot of the big stuff. It's all the little stuff. And chronic back pain is there. Here is the assessment that was done by our crew, and it's a great assessment. Look at these notes here. Discomfort in the lower abdominal area, below the umbilicus, no rebound tenderness, so we know that they palpated the quadrants there of the abdomen. Bowel sounds are present, no guarding noted. That's really detailed. Under the back category, lower lumbar pain, history of chronic spinal stenosis. And then you can read all that other stuff. But we have a very good detailed physical exam on this patient. Here's the rest of the initial assessment. No abnormalities in most places. The pulse is there. Everything looks good. Here's the narrative to this 911 call, and you'll see that right here, per staff, patient was attempting a bowel movement when he began complaining of lower back pain. He has a history of chronic spinal stenosis. Staff report no trauma, no loss of consciousness. He was assisted back to his recliner by the facility staff. So there we have kind of everything surrounding the chief complaint. And during the transport, you'll notice that even though that there's back pain, there was no interventions like pain management or IV access. And here the crew explained it. The interventions were discussed with the patient and he declined. You got a chronic back pain patient. He becomes a 911 call during a bowel movement. And he declines the IV access and declines the pain management. Think about it. How much are you going to argue? So when the ambulance gets to the hospital hears everything that we saw in that patient care report. They get the transfer of care, and they process this patient as a chronic back pain patient. A long time passed, an hour to an hour and a half, that patient was at the hospital before they were checking off what are the last things we need to get out of the way here on this patient. Oh, we didn't run a 12-lead yet. Do we really need a 12-lead? I don't know. Finally, they said, you know what, go ahead and run the 12-lead. And what do you suppose the outcome of the 12-lead was? Of course. So back to the hospital we go. And here's the second patient care report on the same guy on the same day. It's your 77-year-old male, but here under primary impression, it's ST elevation myocardial infarction. He's in the middle of a STEMI. Here is the patient care report from our second transport, and look at that second paragraph. Receive report from sending staff stating the patient originally complained of back pain and nausea after waking from a nap. Yeah, I'm just as surprised as you are that they completely changed the origin story of this call. We know that this call didn't start after a nap. He was in the bathroom. So just take it with a grain of salt that nurses can and do change stories, and they put in their own generic details when there's a blank space that they're trying to fill. We hope that they give accurate reports, but in this case they did not. But I call your attention to the last paragraph where they're running on down the road, lights and sirens going because they're on their way to the cath lab for the STEMI, and suddenly what happens? The patient now develops a third problem, back pain, heart attack, and he goes into a seizure. The vital signs are listed here, and you'll notice in the third set of vitals, when the patient is seizing, the blood pressure went quite a bit down. The whole body relaxed. It was probably a good thing for his heart. This crew is also very thorough. Here we have a 12 lead that the crew took. Let's take a closer look at this 12 lead and see what's going on. Let's take a good look at this 12 lead. And the first thing you'll notice is the little squiggly lines here for the heartbeats are pretty far apart. In fact, that is a very slow heart rate. The monitor is counting 32 beats per minute. What else can we see here? Well, in leads 1 and AVL, I see ST depression. And in leads 2, 3, and AVF, I see ST elevation. And if you have ST elevation in 2 or more contiguous or leads that are right next to each other, that is a STEMI. So what was I seeing when I talked about seeing ST depression and ST elevation? Well, what I'll do is I'll take my nifty little isoelectric line here, which I'm going to line up right here. And as you see, this more or less is right where the baseline of the electrical rhythm is. And you'll notice that right here we have just a little bit of ST depression. It's not coming all the way up to the isoelectric line. If I move my tool down over to the next contiguous and kind of line it up there, you can see again we have this ST depression right in this area. Doesn't quite go all the way up to the isoelectric line. Let's try moving this to the inferior leads where I have ST elevation. I'm going to line it up to kind of the bottom there. And you notice we have ST elevation right here of about 1 millimeter. Continuing over here. Here it's much more obvious. And you have definite ST elevation right here. And we can move it over to this one. All three of these are contiguous leads. They're all inferior leads. And I have elevation here too. So that's what we're talking about when we see ST elevation and ST depression, is the failure to return back to the isoelectric line of the rhythm when it's supposed to. And that's why this is a STEMI. But that's not all we have in this 12 lead. There's something else going on too. If we take a look over here, you can see it in other leads too, but we're going to look over here on V1. Do you see these little bumps? Very regularly spaced, and many of them. Now you can see these in other leads too. I see them here. I see evidence of them here. You can see them here. It's a little unusual to see them in the other leads, but in lead V1, which is the best lead to see atrial activity, right here what we see are sawtooth type marks on the isoelectric line, which means what we have going on here is atrial flutter. So we have the atrium kicking off 1, 2, 3, 4, 5, 6 times before the signal finally gets through to the ventricles. Here's the next signal getting through here. So it's a 6-to-1 conduction atrial flutter. That is really, really slow. So this is a very surprising 12 lead for somebody who had back pain during a bowel movement. I did contact the final hospital that he was transported to, the one with the cath lab, and they sent me a patient follow-up report which covered everything from the first ER to the second ER to the cath lab. This is the 12 lead that started everything off in the first ER. It's very similar to the 12 lead that our paramedic took. You can see the ST depression in 1 in AVL. You can see the ST elevation in 2-3 in AVF. And you can see in V1, both up top and all the way across the bottom, where you have a nice long rhythm strip, the sawtooth pattern that's consistent with atrial flutter. Okay, so very, very similar 12 lead, and this is the one that started the whole thing off. He was taken to the destination hospital, which had a cath lab, and this is the angiography report from that cath lab. And you can see here, this is the right coronary artery, which feeds the right and inferior part of the heart with 100% occlusion. And here is the mid-LAD, or the left anterior descending artery, again with 100% occlusion, and 60% occlusion of the circumflex, which feeds the back of the heart. So this is all very consistent with the 12 leads, right? We knew we had an inferior STEMI. Wait, hold on. What are these blue things? Well, these blue things are the fact that the patient had a coronary artery bypass graft surgery. He had a cabbage. So this 100% occlusion, well, that's why they put in this bypass. So this isn't new. And same thing here. The MLAD had this 100% stenosis. That's why they put in this bypass here to feed the bottom of the heart. So down here is the new stuff. The 99% occlusion in this branch and 75% occlusion here in this branch. This is what was currently causing this patient the problem. This circumflex at 60%, my understanding is they don't normally stent at 60%. It needs to be higher than that. But if they're already in stenting somewhere else, they will stent there as well. I don't know if they did it on this patient, but this is the area that was causing the emergency that day. And all this stuff is old. So you see we have a clot here and a clot here, or we have stenosis here and a clot here at the minimum. So this guy, to use a highly technical term, is kind of clotty, isn't he? So what else could possibly happen with this back pain while having a bowel movement, off to the ER, suddenly it's a STEMI, on the way to the next ER, he has a seizure too. What else? He had a stroke. And that's why you have to be open-minded and prepared for the calls that come up to bite you in the